yourselves, applaud for your coworkers, you know, come on, don't make me do it by myself. Thank you. Couple quick introductions that I want to make this morning to our two most recent members of the KPQC team, and one by one, Carrie, if you'll just stand or wave or something. Carrie Smith, she received her Bachelor of Science in Health Science and Public Health Education from Clemson University. She went on to obtain additional degrees from Johnson County Community College, University of St. Mary, and her Master of Science in Nursing Education from Oklahoma Wesleyan. Carrie is nationally certified in both inpatient obstetric nursing and electronic fetal monitoring. She is an A1 intermediate and advanced fetal heart monitoring instructor and has been published in the Journal for Nurses in Professional Development for her advanced work in development of use of nursing simulations in obstetric sepsis. Carrie currently serves as a clinical nurse educator at Advent Health Shawnee Mission and is co-chair of the A1 Kansas City chapter. And then we also have Jill Nelson. Jill, stand, wave, make sure everybody knows who you are. Jill joins the KDHE Bureau of Family Health from Johnson City, Geary County in 2011 after a call to action that identified her community as one of the worst in infant mortality in Kansas. Jill helped to build and lead the Delivering Change, Healthy Families, Healthy Communities, Kansas Perinatal Community Collaborative, whose collective impact work has decreased infant mortality by over half and has improved maternal health outcomes. As Sid's parent, Jill holds a deep passion and interest in improving the health of mothers, infants, and families in the state of Kansas. Jill holds a bachelor's degree from Kansas State University. She and her husband, David, are parents to Isabel, Kale, Emmeline, and the late Luke Nelson. So thank you both. And that's all I have. Should I read this or turn it up?
Let's see here. Sure. Oh, it's great. Testing. Oh, yes, it's working. You want this one back then? Perfect. All right. Well, there's our fearless leader. Thank you, Dr. Nguyen, for the introductions this morning and for welcoming everyone. All right, well, here is our agenda for the day. We are thrilled to have so many of you here in the room with us and those of you joining us online. We are in for a great morning of learning together, which is always a great thing. We will introduce the executive committee during our meeting this afternoon, right after we conclude our learning forums this morning. But this is our executive committee, and we will introduce those who are here with us in the room and those who are joining us online a little bit later. All right, so I want to give just a few updates from the KPQC. I wanted to let you know that as we have been engaging stakeholders across the state, one of the groups that we know has been kind of missing from the conversation have been our payers, right? We know how important the insurance and those payers are to this conversation about improving maternal mortality and improving maternal morbidity. And so just as an update for all of you, you will be hearing this morning from Blue Cross and Blue Shield from Virginia Barnes, who you will be hearing from here shortly about the work that they are doing to improve outcomes in the state of Kansas. And then we have also engaged just recently with the United Healthcare National Maternity Care Team, I believe is what they were called. Tara, Carey, and I met with them a couple weeks ago. They wanted to learn more about the work of the Fourth Trimester Initiative and what's happening here in the state of Kansas. So we wanted you all to know that we are engaging our payers, and we know that they are critical to this conversation, and we're going to continue to reach out and hopefully engage more, especially our MCOs here in the state of Kansas around that. I am also really thrilled to announce that we have a new professional partnership. Tara was invited by our partners at the United Methodist Health Ministry Fund to speak to the Kansas Academy of Family Physicians earlier this month, specifically around how to optimize the postpartum care extension and how family practitioners play a role in that work. And so after Tara gave that presentation, they said, we are all in. So they are the latest partner professional organization to join our stakeholders that are saying not on our watch. So we are thrilled to have them as part of our team. Just as a reminder to everyone, as we talk, and there's always a question about the data and where are we getting the information from. So as our fourth trimester champions and team members here in the room today will learn more today about inputting the QHI data and gathering data around the AIM postpartum discharge transition bundle. But that is data that we will be looking at going forward. And we have been gathering that, but just not on an individual basis where they were putting it into the system. So we'll be learning about that today. And then just as a reminder that we always look at our KDHE annual summary of vital statistics, which the 2021 data is released and is available on the KDHE website. We look at the PRAMS data, which we also have a brand new report. It is 2020 data, if I believe correctly. And then of course, our Kansas Maternal Mortality Review Report, which covers from 2016 to 2020. That we have been using that data preliminarily. We are waiting on the official approval of that report so that we can post it publicly, but it is pretty much ready to go. Finally, some exciting news, and maybe something that not everyone is aware of. The Centers for Medicaid and Medicare are releasing a new designation this fall, which will go live, called the Birthing Friendly designation. If you remember last June, the Biden-Harris administration released a blueprint to address the maternal health crisis, and it outlined ways to advance equitable, high-quality maternity care provided by hospitals, which is this designation, and also through the president's budget for 2023, they are supporting a perinatal quality collaborative in every state. And of course, Kansas had our perinatal quality collaborative was established in 2018. So the first designation of this will go live this fall in 2023. And this is the first publicly reported, public-facing hospital designation on the quality and safety of maternity care. So how will this work for hospitals? CMS will award this designation to hospitals that report yes to both questions in the maternal morbidity structural measure, which is that you are participating in a structured state or national perinatal quality improvement collaborative, and you're implementing patient safety practices or bundles as part of these QI initiatives. So the good news for all of you who are enrolled in the FTI project and are working on the AIM postpartum discharge transition bundle, your hospital is able to answer yes to both of these questions. So you should receive the designation of being a birthing friendly hospital. So that is coming down the pike here in the fall of 2023. I'm not sure when exactly and what years they're going to start gathering this data, but it's supposed to go live here this fall. So just another great reason to be engaged in the fourth trimester work and in the work of the AIM bundles. And at this time, I'm going to turn this over to Carrie Smith.
Hey, good morning. So I feel like I get the exciting part here. In addition to working on preparing for our spring conference, we've also been very, very busy getting ready for our fall conference. So KPQC has partnered with Kansas A1 to have I'm going to call it a big conference just because I'm a big dreamer and I envision that this is going to be super exciting and go big. But we wanted the focus to really be maternal mortality and who's at the table of change. So a big thing that I've learned since being in this role is that there are a multitude of people on the inpatient side, as well as community members who are all out there working for the same cause. How can we all work together to improve our maternal and neonatal outcomes? So our plan for this conference is to get those people all at the table. So we will have leads in our clinical professional organizations with ACOG and MFMs and A1 and our midwives, family practice, our peds, all of them, as well as panels of community partners who will be there to speak to what we are all doing, so that we're not reinventing the wheel, and that on the inpatient side, we realize that the weight isn't intended to be on our shoulders alone, that there are others out there to help. So our keynote speaker will be Ginger Breedlove. And our goal is within the next month to have a bigger flyer with registration links and all of that sent out to everyone. So stay tuned. In addition, if you guys were on the March Learning Forum, I did a big talk on data, which could put many to sleep, but at the same time, I am a big nerd, so I thrive off that. But KPQC is also constantly keeping abreast of what it is that's impacting maternal outcomes. So we've shared this report before in several actually of our meetings, but just looking at how COVID impacted, how did the pandemic really impact our maternal outcomes? We saw it in the hospitals, we saw what was happening there, but even greater, what was happening to the women prior to even getting to us in our facilities. And you can see the data showing how our maternal deaths greatly increased around that time. I think this speaks even more, as showing that we saw our patients and continue to see our patients so much more frequent prior to their delivery than what we see on the postpartum side, which is really what drove the 4th trimester initiative into honing in on what we can do to better improve the outcomes of our patients on the postpartum side. So just this image alone, I think, should really speak to and support exactly what it is that we're all here to focus on today, and also why it's important that Jill is speaking to having the conversations with our payers too. If the goal is to change that focus right there alone, we have to fix that piece too. So this just kind of reiterates how our outcomes and disparities worsened during the pandemic. And Tara is going to come up and speak to the next piece.
Good morning, everyone. So I grabbed 2 really fun people to hang out with me today, and I'm just having a great time at our table. So I'm glad you all are here too. And those of you online as well. So this is the really important piece that we do every time we get together to remind us all what it is we're doing. So we talk about data, we talk about convening people, we talk about what needs to happen next, but I'm just going to stop the train and say, this is what we're doing and why we're doing it. So if you remember a couple years ago, we figured out that the data told us that there was a problem, and the problem said that women were being hurt more and dying more in Kansas than we ever realized was happening. So we said, well, what do we do about that? Do we focus in on prenatal care? Do we focus in on delivery care? Or do we focus in on postpartum care? And the data was very clear, and it was all about postpartum and the first year, from immediate post-delivery through the first year postpartum. So we created what now is called the 4th trimester initiative, focused around this general idea. The mom plan, where the mom is the focus, not the provider, not the payer, not the accountability, not just one thing alone, but the mom. The mom was the center of the goal. And we grabbed in the rest of us as her postpartum care team. And it's not just about the medical people, which we believe will create a healthier postpartum mom. Then we said, everybody jump in. And to date, we're really excited to announce that we have 31 sites. That is a phenomenal number. If you remember 2 years ago, my personal goal was 90% of Kansas births were impacted by 4th trimester work. We've had a little bit of we thought was a plateau about a year ago, and all of a sudden there's great interest. I'm going to pretend like it's not about the CMS initiative and that we aren't being motivated by people like Jaco, but I do know better. I also think that there's synergy around the fact that maternal health, I don't know that everybody understands that something has happened in Kansas. And the more we talk about it and we say, there are some really adverse outcomes happening, folks around the state go, I want to be involved. It's moms and babies. And so you see this jump in happen. And I get to talk to hospitals that are going, we thought it was just our community, or we thought it was just our hospital. And we're all going, no, we're all in. We want to help, and we want to make things better for our families in our state. So you can see there on the right-hand side, the list of the facilities that are now enrolled, impacting 84% of births. You see that the numbers of 4th trimester births are listed. I would only stop to remind you that these are the live births occurring. We all know that stillbirth is extraordinarily important, though not counted in that number, just as extraordinarily important, if not more so. When we talk about checking ourselves and how do we know that what we're doing is really the best practice model? And are we talking to all the people we should? Remembering that mom is at the center of the goal. We knew at the table that we needed to involve more people at the table to check and balance ourselves with our best practice models. The folks that are on the slide right now are data folks, certainly community level folks, state stakeholders, and then our professional organizations that really are all championing efforts to improve maternal and infant health. The issue is, you all are probably seeing it too, everybody's coming at you with their best practice model or their QI project or their data source. And I feel personally responsible to try really hard to get everybody connected as much as possible. And when I talked to the family practice group, they were already interested. In fact, they were ready to act that day. What can we do at our practice level to help moms be healthier? The truth is, all we need to do is connect dots. Everybody's saying the same thing, but nobody knows where to start. And so these folks are at the table saying, we want in, let's do it intentionally, but what are the best practice models that we need to be investing our time and our efforts in? So the 4th trimester initiative is now centered around what we're calling the new postpartum model in Kansas. We believe that the way we will impact maternal health and decrease morbidity and mortality is listed above. Education on post-birth warning signs at every postpartum event, live birth, stillbirth, or otherwise. That the postpartum appointment is made prior to leaving the birth setting. If there was a game changer, it's that. The postpartum care team, as indicated by what she needs. It does not mean that a rural practice hospital and a tertiary care center all have the same care team. It means that she is given access to whoever she needs as closely as we can find it. That the following screenings are completed on her or with her prior to discharge: social determinants of health, mental health, medical risk factors, breastfeeding, and family planning. Therefore, based on screenings, standardized and done prior to discharge, referrals are made either in-house or immediately upon discharge. So the soft handoff or warm handoff happens also on those same indicators. A navigator, vitally important. I would say to you as a provider, I would say to the bedside nurse, I would even say to the family members going home with the new mom and dad, the birth couple, and say they need help and the providers can't do it alone. The nursing staff can't do it alone. The triage folks can't do it alone. Peds can't. The thing that we know we have in Kansas is a strong outpatient public health connection. Funding is available for every single Kansas parent to have a navigator assigned to them. So that if a hospital and the outpatient clinics can connect them with a navigator that helps that patient and that family through the system, we know outcomes extraordinarily improve. So again, one of the things that we should assume in Kansas is that every postpartum family has a navigator. Again, live or stillbirth. And then in all caps with 3 exclamation points is birth equity. There is no room for us to miss that part. It's not last on the list. It's the most important. Carrie is going to spend some time in a second talking about the drill down of the projects that are within 4th trimester. For those of you that have been with us from the beginning, you know that it's an overwhelming list. I realize and recognize that we keep throwing things at you and asking you to do more. While your capacity is increased, while your patient acuity has increased, and why we are tired. We are a tired people. However, folks like pictured there who are completely biased, because that's my group of people from my hometown in front of me, are doing hard things. And The projects within first trimester, you all mean outcomes measurement changes. So when Carrie talks to you about all of those and we figure out in the room, and for those of you on the virtual side, how can you do your part? How can you make an impact? You don't have to be a birthing setting. You can make an impact on one or more parts of this project, and it will lead to improved outcomes significantly in your community. Also, just as a reminder, we are talking about state level, we are talking about community level, we're talking about hospital level work, but we are the only state that is enrolled in the AIM bundle called the postpartum discharge transition. What that means is that we are creating the new postpartum model that will be assumed to be the care across the country. Please do not miss that. When you talk about the work you're doing at your local level, you need to talk about the fact that we are nationally renowned. That's the word you should use. But we are doing work that really will impact, we hope, the way that the entire nation changes its postpartum model of care. So when it feels cumbersome or it feels a little unclear, it's because we are really unearthing the new way to take care of women, and it's sometimes a little tricky. You this afternoon, those folks that are in the room, will have opportunity to talk to most of the people that are involved in the projects within first trimester. If you're on the virtual side, please reach out to us if you would like to connect to a specific person or group within the projects that are mentioned. But I wanted to pause just for a second to talk about an upcoming workshop that's available for the providers through the Kansas Connecting Communities group, which is the focus of maternal mental health work in Kansas. That QR code, if you use it with your phone, you can register for this screening for substance abuse disorders workshop. I will tell you all, and the data is, I was on an opioid educational webinar last night. If there is something that needs to change, it is substance abuse recognition and referral. We are in a very important piece of that, especially with our patients with chronic pain in pregnancy and postpartum, certainly also with those who end up with a surgical delivery, and those who, of course, then follow postpartum. And what is the critical moment inpatient that we can do to help women not go forward with substance abuse or to be heard that they have a substance abuse disorder? So our friends at KCC have opened this up. Wanted to make sure we shared it across the state as an example of some connections that we all can make to improving outcomes. Carrie?
So part of what we're going to do this afternoon is that we will give all of the facilities that are in person a report card just to show you what you've accomplished at your facility and then what's to come, what's in progress, and what haven't we initiated yet. I think just looking at this list alone, it's nice to see that there are things we should check off our list. What have we done? Because we're always, like Tara mentioned, giving the what's coming next. And sometimes, I don't know about you, but I'm a visual. I need to know, check, we've done this. We should celebrate that, because not a single one of these items is a small task to achieve. So what have we done? We've done the education for post-birth to our staff and hopefully integrated that into all of your postpartum discharge teaching for our patients. We have the magnets, and Joe will talk about later. We've got some more of the mom cards in the back that you guys can collect. We have addressed breastfeeding. Many of our facilities are high five or baby friendly designated. And then initiated the KBEN education, so our birth equity education. Champions that have started or completing that education, and the next step will then be to implement that same training throughout your entire facility. So that'll be a two-part piece there. In addition, what's coming, our ED triage question. So I don't know about you all, but I feel like it took us a little while to be able to get the verbiage implemented into our emergency departments for every woman who came through. Have you had a baby within the last 6 weeks or 42 days? What we've learned through this initiative is that actually we need to be asking, have you had a baby within the last year? Because a lot of what we're identifying is that our maternal mortality actually extends throughout the first year. So making sure that that piece is implemented into all of our EMS areas, as well as our emergency departments. The second piece of the KBEN training that I talked about, ensuring that we have a community resource list at our facility, so that, again, like I mentioned earlier, we don't feel like it's our responsibility alone on the inpatient side to fix or solve all of the problems that we have, being able to give those lists to our patients to say, okay, these are the partners that we work with that are going to help you in that situation. Ensuring that every patient is screened for social determinants of health. And then what are we going to do about that? Not just screening, but what are we going to do about that? And then our postpartum visit template. One of our tables that we will break out this afternoon, you'll see on the agenda. We have a little think tank session where we will break out into 6 tables. And one of those is looking at our postpartum visit template. As AIM is saying, it needs to be standardized. So there are certain components that need to be included in all of our postpartum visit templates. And then postpartum visit scheduling, making sure that every patient has an appointment set up for her first postpartum visit prior to discharge. So those are things to come. Going back to that image that Tara showed, I'm a visual person, so I needed to have something in front of me to look at what it is that we're trying to accomplish, and then what are the other little pieces that we're integrating into that all make up what we're hoping to achieve, what we will achieve by the end of this initiative. So each of those pieces, maternal warning signs, we talked about implementing the post-birth, maternal mental health. We should be screening every patient, whether it's for the Edinburgh discharge or Edinburgh postpartum depression tool or another resource. But more importantly, if they screen higher, they answer yes to number 10. What are we doing to ensure that we're not just passing that information on to the OB, but instead making sure that our patient is connected with someone and cared for in a timely manner? Birth equity through our KBIN training, the postpartum appointments that we talked about, breastfeeding, and family planning, making sure that that conversation and action is being taken care of with our patients prior to discharge of how do we want to move forward with our family planning after this. And then you can see all of those little pieces that I mentioned in that list below, or list before, that we are conquering as well. What you'll see on your report card, rather than overwhelming you with all the pieces, is intended, it's cheesy, but I did it, to look like a little sunflower to represent Kansas, so that you guys can see via color code what's not started, what's in progress, and what you've already completed. So it kind of gives you an idea of what have we already tackled and what do we have left to do. So for those of you who are joining virtually, if you want your report card emailed to you, just send us a message in the chat or email one of us, and I'll make sure that we can get that out to your facility too. All right, Jill.
All right, sorry, I had to pull up my bio here for Miss Virginia. All right, wonderful. Well, our first presenter today is Virginia Barnes. She is the Director of Blue Health Initiatives at Blue Cross and Blue Shield. Virginia has been serving as the Director of Blue Health Initiatives for Blue Cross and Blue Shield of Kansas since October of 2015. Blue Health Initiatives formalize the company's longtime efforts to improve the health and quality of life of all Kansans. The term social determinants of health is more than just a buzz phrase for Virginia. Her work is dedicated to moving the needle on health inequities across the state and improving the quality of life for all Kansans. Blue Health Initiatives has distributed more than $25 million since its inception to improve the quality of life for all Kansans. Ms. Barnes has over 15 years of public health experience, having worked for the Kansas Department of Health and Environment in a variety of roles prior to joining Blue Cross. She earned a bachelor's in biology from Washburn University and a master's in public health from the University of Kansas. Barnes currently serves on several boards, including the Kansas Public Health Association, the Topeka Community Foundation, and the Topeka Center for Peace and Justice. She also participated in numerous advisory committees focused on improving health in Kansas. She is a lifelong Kansan and lives in Topeka with her husband and 2 children. We are thrilled to have Virginia join us today. Wonderful. Well, good morning.
Well, good. In 1 second.
Well, good morning. And thank you all for having me today. So again, appreciate being invited to be a part of this meeting today. This is really as Jill mentioned, I've worked at KPQC. I feel I'm a public health generalist. I think I did infectious disease, surveillance, bioterrorism, immunization, chronic disease. I did not do maternal health. And so this is actually great I've learned a lot over the past year or so, and I'm really excited to be able to dig in a little bit deeper into this area of what I consider an important part of public and population health. So I want to start out today to give a little bit of an idea of my role within Blue Cross and Blue Shield of Kansas and talk a little bit about that larger, broader commitment that we have made through our Blue Health Initiatives work. And then I'll pivot and kind of talk about how this all comes together around our commitment to maternal health. So Blue Health Initiatives, as stated, was started in 2015, and it really is looking at how do we make that long-term impact on quality of life. How do we take a look at our communities and our populations and say, how do we, as the largest commercial insurer in the state, actually help make improvements to health that will truly make a difference? And so we do that through 3 different areas currently. That's our Pathways to Healthy Kansas initiative, which is our largest grant initiative ever through Blue Cross and Blue Shield of Kansas. And it focuses on working with local health coalitions to improve community health holistically across 24 communities that we're currently funding. Trailblazers work is really about how do we look at what's new and upcoming, what's innovative, what are the technology changes that are coming that can help us improve quality of life, and what are the different ways that we can think about things such as economic stability or coordination of care differently than we have before, and help pilot and get those to become a part of the system. And healthy lifestyles work is really kind of what it sounds like. It's really those environmental changes within communities that we can help improve people's access to living healthy and having healthy habits. So those are kind of the 3 big buckets of work that we have focused on since 2016 when we started Blue Health Initiatives. And all of this is based around this premise, I'm sure you've all heard, that there really is good data that says there's more to health than healthcare. So we know that truly when we talk about social determinants or social drivers of health, that's about 60% of those social, environmental, physical, behavioral factors in society that impact our health and improve and our health outcomes, good or bad, outside of healthcare and outside of our genetics. And that really is the broader picture that we've been working on to be a part of that work. I talk about this a lot just in the context, this is the CDC's health impact pyramid. And really all of these are great ways to intervene for public health. When we look at our Blue Health Initiatives work, we're really focusing in on that change in the context and socioeconomic factors. So what are the bigger projects that we can put out there that impact policy changes, environmental changes, really look at the poverty, employment, education, those really big systemic changes that we know really will make a difference. So again, supportive, of course, of all the more individual changes that most of you work on, but that's typically not where my focus is with Blue Health Initiatives. And so as mentioned, some of the pieces that we're really focused on is those social determinants of health. So we have been incorporating, based on the Kaiser Family Foundation social determinants example, incorporating that into all of our initiatives over time, and really thinking about, again, not just what are the ways that people, I tend to say, I think a lot of times people think of the fluffy work, like, oh, we get to be on bikes or eat healthy. And that's public health. And that's really, truly a part of what we do, but really understanding how does having that access to healthy food, having that access to physical activity, having access to resources actually change the context of social determinants. And then finally, as you guys have talked about, birth equity, for instance, being the most important. We are trying to be very mindful as we build out initiatives across the state, that we're not just looking at, again, doing just what sounds fun or what we think of as equality, but really taking that the equity and justice lens. So who's experiencing the health disparity? Why are they experiencing it? What's the historical context of why they're experiencing it? And how do we engage them as a stakeholder in the initiatives to make sure we're hearing voices where within the work and not simply putting things out that we think are right. So where does this kind of connect back to maternal health? Of course, in 2020, with the pandemic and with the social justice movements that we saw come out of 2020, the Blue Cross and Blue Shield Association did recognize that there was a bigger role that we should be playing as the Blues across the United States. And so in 2021, the association did put out our National Health Equity Strategy. And this is really that top piece focusing on what are the ways that we as Blue plans can have an impact on health equity. And, those started with some fairly obvious ones in terms of actually collecting data to measure disparities. Most commercial plans, most health plans really weren't doing that. Actually, taking the effort further and actually scaling those effective programs that we know can make a difference. Working with providers more closely to look at those outcomes and address unconscious bias. That was a big piece of the work. Leaning into partnerships at the community level, and then as an association, understanding how can we actually be more influential in policy decisions, both at the state and the federal levels. So we are an association. That means we are a part of the larger membership. This is not a mandate. We do not have to do this. But Blue Cross and Blue Shield of Kansas, with our leadership, looked at this and said, yes, absolutely, we will do this. This is important to Kansas, and we do want to be a part of this work. So that's kind of I would say the first big step we took towards having a more explicit health equity lens within Blue Cross and Blue Shield of Kansas. And then with maternal health, so the larger National Health Equity Strategy looked at sort of 4 areas: maternal health, behavioral health, diabetes, and cardiovascular disease or cardiovascular health. But started with maternal health, just recognizing how glaring the data is around maternal health inequities, and started with this very big, bold goal to reduce this racial disparities in maternal health by 50% in 5 years. So for any of you who work in public health, like 50% in 5 years, that's insane. Let's just do 1%, and that'll be an amazing accomplishment, So I think I read this 3 times when I first saw it. I was like, do they really mean 50%? But that's the goal, and I think it's audacious and amazing, and that's what we're doing. So this is Kim Keck, who is the president and CEO of the Blue Cross and Blue Shield Association. She came out of the Rhode Island plan, and she's really been a huge advocate nationally for this National Health Equity Strategy, and just really pointing out how very clearly the data supports that we need to do more around maternal health and more around racial equity within the healthcare system. And so just also recognizing that truly where you live should not be the major driver of your health, and talking about how we have very much a responsibility to do more. So a big part of what we did as an association was adopt this first big call to action, which is the top 10 maternal health equity actions. I know these are very small to read on the screen, so I'll just kind of summarize each of them. But one was really just engaging more maternal voices and community stakeholders. So really, who's already doing great work in this state? So you guys come to mind. But truly making sure that as we look at how we are addressing social determinants, how we're looking at root causes. Again, we're not just going out as a health plan and saying this is the data and this is what we're going to do, but coming at it from the community context. There were a couple of different areas where unconscious bias and health justice are called out within these plans. Cultural humility and unconscious bias training is a really big piece of what the association has been supporting across all the plans, and making partnerships both with March of Dimes, but also with any local partners such as KBEN that are doing this work. Other states are probably a little bit further along, and I did try to sort of star the places that we're probably doing the most work in Kansas. But other plans are doing a lot of very good work around understanding how they can include nurse midwives and birthing centers more to increase education for members. I would say that's something that I'm open to learning more about it, but we haven't as a plan probably connected there as well as we can so far. And there's also the facilitating access to doulas and community health workers for maternal support services. As a commercial plan, again, we haven't done a lot, but we are paying a lot of attention to how this is shaping up with the Medicaid plan with CanCare currently, just to understand how that can then be connected back to Blue Cross and Blue Shield of Kansas as a commercial payer. And the implement facilitated self-management or peer prenatal care models such as centering pregnancy. Again, this isn't something that I have heard or seen a lot of work in Kansas. If any of you are doing centering pregnancy work, I'd be really interested in speaking with you. I know a lot of plans have really focused in on this piece. And again, this was not a part that we have done as much with in Kansas. And then on the other side of this, extending benefit coverage to cover postpartum care, including behavioral health care for 1 year post-delivery, align quality measurement with national standard settings, and setting organizations that tie back to provider quality programs. So we are taking a look both with our quality, our QBRP initiative in terms of how do we tie it back to QBRP, and then understanding, again, there's several plans who are actually doing some really broad health equity value-based work. And so we are trying to stay aligned with what is coming out of NCQA and HEDIS and the other pieces, and then kind of understand how we can put that into action here. Join and participate in your perinatal quality collaborative. I was actually excited. I felt like I could actually very much brag about Kansas and be like, well, we've had an amazing quality collaborative since, again, 2018. And that's truly isn't the case. And a lot of plans did not have such a strong group to come and connect with. So I applaud you guys for all the work you've already been doing, and happy to be able to connect and be a part of this as well. And then implement value-based contracts specific to maternal health. Again, this is something we haven't started, but are looking at. And finally, amplify programs to special significance, such as vaccination programs with a focus on COVID-19 and influenza. So we've been pretty supportive of vaccination and supporting getting vaccinated for COVID-19 and influenza. We will continue to support that and look for ways that we can help boost, especially knowing that childhood vaccinations have really taken a dip since the pandemic as well. So that is the big kind of 10 steps that is publicly on the National Health Equity website for the association. So again, you don't have to read a tiny slide. You can actually go take that infographic and pull it down if you have questions about what's being done. And then I wanted to highlight a couple other resources that are out there. So the association has really done quite a bit of work. They have numerous articles out on their website that come out of the Health of America reports that Blue Cross does. And this is one I just wanted to highlight around racial and ethnic disparities in maternal health that was put out, I believe, last year. And this one I thought was particularly helpful report because it actually looks at both commercial and Medicaid data. And I do, my personal opinion is that a lot of times commercial payers get off the hook for this work. They say, oh, that's Medicaid. Oh, we don't have the same issues with our populations. And I think it's been very evident with the findings that is not the case, especially with maternal health. We are seeing similar disparities across commercial populations as well. So I wanted to highlight a couple of the pieces that were in the report. So it did show that the SSM rates are substantially higher for Black, Latina, and Asian women. The blue shows the commercial side, and orange is Medicaid. And this is really looking at data from across nationally, across all the Blues plans. So we have a pretty big piece of the market, and we can truly say that looking at the commercial and the Medicaid data, that truly, it's not just one or the other. So I think that, especially when you look at the rates, we're 53% higher, and with Medicaid, 73% higher. Sorry, commercial is 53% higher for Black women and 73% higher for Medicaid than white women with the SMM rates. Again, that's just unacceptable. So a couple other pieces of data looking at the age and delivery with 6 weeks postpartum. Looking at those rates, again, we continue to see a really big disparity when we look at it across race and ethnicity. And I think just a huge impact, especially in that ages 35 to 44. So that does show you both the commercial and the Medicaid data for this within the report. And again, just highlights that it is a critical issue and across that age group specifically, or especially, I should say. And then it gives some additional data across each of those risk factors and just shows when you look at the prevalence rates broken down by race and ethnicity, what are the differences? And again, this is in commercial women with commercial insurance. So just showing that, especially when you look at the preeclampsia, the percent difference with Black versus white is at 61, chronic hypertension 78%, anemia 70%, just really huge percentage difference there that show we do have a problem when you do need to tackle it. And again, this kind of just highlights additionally from that report who has the highest risk for SSM. Black women aged 35 to 44 with multiple risk factors are at the highest risk. I think another thing that I like about the way this national health equity strategy has been laid out, and it's kind of talked about a little bit too, with some of the other pieces you guys are focused on. It started with a big focus on maternal health equity. We know that behavioral health, substance use, mental health pieces of that are a huge part of this. That is sort of the second piece that they are layering on and building. So how do we understand, how do we help impact mothers and birthing people, and then how do we understand how that connects to mental and behavioral health? And then of course, diabetes and cardiovascular disease are huge risk factors. So we'll very much layer and hopefully have that sort of larger holistic approach to how we can make an impact as well. And I think that just kind of shows here too with when you look at the age group and you look at the other risk factors, they're not just pregnancy related. There are substance use or they are mental health as well. And then I just want to include this if you are just looking for additional handouts or fact sheets or information. Again, I'm a data person, so I like to include resources as much as possible. Like I said, the Health of America report has a huge number of articles, pieces of information, handouts, and fact sheets. So this is just an example of one of the fact sheets. Again, it's national data, but it gives you a really good understanding of it across the spectrum, and it is showing truly that it doesn't really matter where birthing people are, where mothers are, they are experiencing the same issues. This is supposed to have animation and it does not. So the other resource I really try to tout for folks who are data people is that we do have a national health index. So Blue Cross and Blue Shield has had this for 4 or 5 years now. And what it does is it's an index that shows for every single county across the United States, what your an index between between 0 and 100 of what is impacting quality of life or quality of health most within your population. And so it looks at all of our commercial member data. And if you look at that top national health index comparison, it says, okay, so the United States broadly has an index score of 92.7 and Kansas has an index score of 92.5, which means Kansas has a slightly lower health index score. So we're slightly more unhealthy than the rest of the United States. And then that second slide that you can't really see takes what are those health deficits, and it actually breaks it down to what are the things that are most impacting health within your state, and you can actually break that down to the county level. And we have enough data that really pretty much all counties, you can get pretty good data for what are the biggest impacts. Typically it's diabetes, heart disease, major depression, and mental health issues really have been high in the last several years. But just gives you an understanding of what are those pieces that are within our commercial populations that are really impacting the overall health of our state. And then it gives some demographic comparisons too. So you can see by the blue nationally is a little bit better across the board in this situation, except, well, actually it's not across the board. I just take that back. It's are better than women and for all gender. For some reason, our men are doing better. I don't know. I don't quite believe that, but I think it has something to do with who gets care in the United States. But that's what the data shows for our populations. And then it does look at the national and state data by age, which this is from, this has been updated just in the last 2 or 3 weeks. So this is last year's data, or so 2021 data. But I think one piece that was really important that I always try to point out here is that especially the state data, just especially even in the 18 to 34, we are behind. So we are less healthy. And of course, that 18 to 34 is that same group for mothers who are having more issues with maternal mortality and morbidity. So I think it's just helpful to kind of see what might also be impacting those mothers. And then I want to talk about a couple things we are doing closer to home. So actually here in Kansas. So as I mentioned, Blue Cross Blue Shield of Kansas is a commercial payer plan at this point. We do have our Healthy Blue that we have launched. That is a partnership, so a joint venture with Blue KC and Anthem Group that is looking at going after the RFP for Medicaid. So we are trying to jump into the Medicaid space in Kansas, and we have a lot of really good people working on building out and helping with resources through our Healthy Blue program. And so one opportunity we were able to partner on earlier this year was with the Doulas of Douglas County program to help address racial disparities in maternal health and infant health. Did a diaper drive, and we've been able to support the opportunity for them to expand and help increase doulas in Douglas County. So we have been looking for what are those ways that we can be connected and help right here at home with improving maternal and infant health. Another piece of what we are doing, so as I mentioned way back at the beginning, we have not historically looked at our member data based on demographics. There's good reasons that health insurers have not done that. And so this is a pretty big pivot for us to say, no, we really need to address health disparities, which means we need to understand the demographics of our members. So one piece of what we have been doing is partnering with Blue Health Intelligence to look at race, ethnicity, and language imputed data to just get an understanding of what we might be seeing within our member demographics and start to look at how we can build out and understand where we're seeing health disparities and address those appropriately and ethically. So that is a piece of the work that we have just started. And again, we are starting with maternal health and starting to look at those SMM metrics to understand what we can do better. We are also hiring a health equity manager. We have someone hopefully who is starting in August, and that is a very exciting piece of it. And that will be a position that bridges both my area, which is more of an external role, and works closely with our provider relations and medical affairs team to understand the internal role with interventions for our members. So again, that will be someone who we will bring back and introduce and have be a part of this quality collaborative as well. And of course, we are engaging with stakeholders. So by that, I mean, please come talk to me. Please, if you have questions, concerns, pieces of data you're interested in, areas you want us to focus, you are more than welcome to come and tell me what those are, and I will look at how we can be a part of that work. And that leads to the partnering piece. Maternal and Child Health Equity Conference is one way we are partnering. So this is work that is out of Wichita State University, really focused on how can we help encourage our academic partners across the state to really take a closer look at maternal health, but also from that social determinants of health lens. So this will be held August 25th. If you are interested or you know someone who may be interested, please do share. And if you need to save the date, I'm happy to provide that after my presentation as well. We also have a very strong DEI team at Blue Cross. It's been really building up over the last several years. And so that's another way we are partnering. So this is just our staff and our team out. The picture on my left is Sunny Mickle, who at a Juneteenth event last year that is in Wichita that we will continue to support this year. And then the picture on my right is our team at the Mexican Fiesta here in town. So really trying to make sure we are getting out and partnering with more events and getting more voices directly from the people who are impacted and hearing from our members more directly. And then I want to share a couple other pieces that we have done that are a little bit more peripheral, but focus on mental health and those social determinants that hopefully can be resources for all of you. So again, we have seen mental and behavioral health has just been a huge piece of what has been driving claims and impacting our members over the past several years. So we have been doing a mental health campaign to help get resources out and kind of try to reduce that stigma that a lot of Kansans feel about using mental health services. But one way we have been able to do that, I think is pretty exciting, is this My Resource piece. And so this can be found on our website. What My Resource does is it actually helps folks who are looking for a provider find one who's more specific to their needs. So it has the same background as them, speaks the same language, maybe is looking at their specific need. If it's, a eating disorder, or, you have an issue with suicide or have a very specific need that not necessarily, that you don't necessarily have a provider right next to you, helps with telehealth. So really kind of helps navigate. So hopefully you're getting a better fit provider the first time versus like the 8th or 9th time, which is often the case. So we've seen that be pretty successful. We keep encouraging mental health providers across the state to become a part of that My Resource network and make sure they're, if they have openings, that they're available and make that available to our members. So that is on our website if you are interested. And then the other piece of the work, this is actually some of that Trailblazers work that I mentioned at the beginning of my slides, is the Kansas Community Network. So this is a social determinants of health resource referral network that we've been building for a number of years here, mainly in Shawnee County. We use the WellSky Social Care platform, and we have been working with Stormont Vale Health and the United Way, along with all of these community partners, to build out a community-driven social referral network here. So as you can see, there's almost 400 unique services. That's actually, there probably are more than 400. This is an older slide. But it does allow for healthcare providers, when they screen for social risks, to actually have that direct referral to those community resources and have a bi-directional referral back to understand if their patient has been able to get care. So this is the closed network piece of this initiative. We do have the actual resources available. It's on our website. You can get them across the state, so it does cover the entire state. So if you are looking for a resource, or you have a patient who is looking for a resource and you're not familiar with it in your community, this is on the main page of our website. You can go use that to search. And again, it's social services. So it can be for food insecurity, it can be for financial aid, it can be for kind of any of those social driver type of or social risk type services that might be in your community. And then you can actually print that off. It does print in multiple languages using the Google service piece. You can text it to the patient. You can make sure they at least have the resource. So kind of two different ways to do it. One is a closed bi-directional resource network. The other is just the resources that can be provided, but they're available. And we do encourage folks to use them. So it sounds like it could be a resource for those of you who are trying to get more community resources identified. And that is everything from me. But I really appreciate being able to come and speak with you today, and happy to answer any questions. And I will be here for a while if you come up with questions. So, or need my card, do feel free to come track me down before I leave. But thank you very much.
All right. Well, for those of you who are in the room, on your table is a little QR code for Virginia's presentation. So if you will please scan that and then take the evaluation component. For those of you online, I believe we will be sending the evaluation in a follow-up email. Is that correct, Tiffany? Yes. Okay, perfect. Virginia, thank you so much. I know that we learned a lot just by your presentation. And that data is very interesting, especially when we think about private payers versus our care population, really seeing that this severe maternal morbidity is really a universal issue in our state, and not just confined to our care population. So that was very eye-opening. Really appreciate the resources that you provided. So thank you. While you take your surveys, and for those of you online, we're going to take a quick little 10-minute break so you can stretch, get a drink, get some coffee, and then we'll meet back here about 10:12. So thank you.
Hang on 1 second, Kara. They're having trouble breaking down.
It's. Just start yelling in.
You're good.
Do you need to?
Do I need to reiterate what I just said?
Okay.
Let's see if we can do that again. I was taken aback, and I think that many of us in the room and perhaps even virtually were, when Virginia, in her description of how payers are involved in the fix, noted on this slide and one right before it, that previously understood disparities between Medicaid and privately insured families in Kansas, that perhaps there's not as big of a disparity. And that's not okay. What this slide is showing you is that there are disparities across the board. Virginia, take two. Will you please describe this slide? And then we're going to open it to conversation on virtual and on site in terms of what does this mean for those of us that are doing the work?
All right, I will do my best. Okay. So part of the conversation we were having, when Tara was like, come do that up front, is that so a little bit about this data. So this is data that, all Blue plans we have a larger data warehouse with as a part of the association. So we have all of our, commercial data across plans. And then we also have a pretty big, I think we're about 30% of the Medicaid market across nationally. And so what it does is it gives us a very good opportunity as an association to actually say, okay, what are we seeing? I think a lot of times we see just Medicaid data, or we see just commercial data, or we don't see commercial data, frankly. And when they put this report together this past year, I think honestly, even the Blues were a little surprised, and it spurred a lot of conversation, just because when you do look at those differences, and I think, chance which direction I went. I think even when you read this, the substantially higher, yes, when you look at the Medicaid, it's 73% higher than commercial, which is 53% higher. But commercial is still 53% higher difference between Black women and white women. I mean, so that is still a substantial disparity. And I think what we often weren't seeing was that next to each other was that, yes, commercial insurance is good and may provide better access for a lot of mothers, but it doesn't erase the health inequities that we're seeing within populations. So that is my general take on it. And I think another piece I was talking about is we are not a Medicaid plan, so this doesn't have Kansas Medicaid data. This is, nationally for any Medicaid plans that are Blue. We don't have that currently. So it's not that specific. It does have our commercial data as a part of this larger pool. One thing we are also doing, as I mentioned, is truly trying to dig in and start to build out some of these dashboards internally so we can understand for our Kansas birthing people and mothers, what are we really seeing with our members? And hopefully as we get to that point, we'll be able to actually speak to this a little bit more specifically within our populations as well. So this is a national picture, but it's a pretty strong national picture, and hopefully makes you ask perhaps different questions than you were asking before, or think about your work differently. What else?
Yeah, I mean, I think that's the big thing. And, again, I mean, we're just pounding this point home because maybe this is this was something that was new-ish to me, right? I mean, we're accustomed to thinking that, this is something that we primarily see in our lower income populations and our Medicaid patients, right? But what we're really seeing here is, again, that this conversation that we keep coming back to again and again about social drivers, about the determinants of health, is that those play a role regardless of, at what your medical insurance is, right? And so again, just trying to hammer that point home. And that is where, again, when we go back and look globally at what we're trying to do here across the state of Kansas, as we pull in one piece after another and try to make sure that every person that is delivering here in this state is getting connected to the resources they need, we can't fall back on assumptions about what they may or may not need based on things like their payer status, right? So this was what we started talking about,
Yeah.
because this was kind of the piece that was really, really like intriguing and making you connect to, why are we doing the things that we're doing here? But we'd love to hear if anybody else, again, was there something in this that really struck you, or a question? Is there something about these slides that you'd like Virginia to, dig into a little bit more? And this is open to our online folks as well. So if you've got a question, I think throw it in the chat, because Tiffany's monitoring. And then Tiffany, I think we probably have the ability to unmute as well. So we'd love to hear from other people who, what is or isn't resonating for you here.
You guys, I just want you to talk loud, or I will come to you. Every time. Hi, Nadine. You state your name and who you are.
I'm Nadine Hagmeyer. You guys have not seen me in this forum before, but I'm the person who currently is abstracting the maternal mortality cases. I'm the one that requests the data from your hospital if you unfortunately have those people who fall into that population. I get the data that comes to the mortality committee and then comes to you all for development of resolution. And I just want to say that from an abstraction standpoint, this is very valid in the state of Kansas. I can't tell you exact numbers. Jill and Jamie, our little data person, could, but the cases are, I don't know, it might be 50-50 commercial versus Medicaid. And I see this disparity. It happens. I mean, it can be a doctoral, a Black woman who has a doctorate, who is very educated, who has commercial insurance, and she still dies. So this is very relevant. If you all are not identifying that, please, please, please do so. I don't like it when the cases come across my desk. It's hard. That's it.
It's as if we planted her. Good job, Nadine. Excellent.
Who
Other-
else? How is this information? I mean, what are you going to take out of this that you take back to your place of work, your facility, your role, the work that you do with your own coworkers? What is it about this that maybe is, is it going to, or is or isn't going to change or impact how you approach what you do every day?
This is when the heels were a really bad idea. Okay.
Jill from Hutchinson. I think it's really easy to think and have assumptions when you look at data like, oh, that really doesn't apply to my community. Or, what we see as our patient population set. When you kind of have that unbiased or that unconscious bias already towards how you view that data and what it means for what you're seeing. When you really see like it is your private pay, it is your well-educated, it is your employed with good salaries and whatever else that this impacts equally, it does make you stop and think a second, like, okay, how do we change that? How do you really make that apply to every person, not this group you assume kind of falls out of it for other reasons that, choices or whatever else you want to kind of start applying to that. So.
Yeah, and I did not do a good job with that slide with the National Health Index, but that was one that really hit me when looking at this report and looking at especially this age group, the 35 to 44, and even the disparities with the 25 to 34. There is other data there. They did a big millennial health report, and it shows up on the National Health Index, which again, you can go in, you can look all the way down to your county. And millennial health in Kansas is not good. It does not show well. We are not doing better than the national based on commercial insurance, right? So again, when you think about seeing these in maternal health outcomes, and then you think about the mental health, but we're seeing just this huge increase in mental health and substance use needs, and we're seeing poor millennial health, and we're seeing increase in diabetes. They're all so connected, and it's not great data for Kansas. So I know data sources don't always show exactly the same thing, and there's lags in data. This is pretty recent data. It's either 21 or 2022, so it's they move them pretty quickly, and it doesn't change for the better. I always say that too, like, hey, if it was bad 3 years ago, it's not gotten better probably. And so I think that's just another thing to think about is we have some sort of bigger warning sign data, and it's groups like this that have to kind of run and make the changes to change the trajectory. So.
Sorry, and I don't know that I knew that either, but maybe
For the
just,
online.
okay, thank you for the online folks. Not sure exactly how this will tie in, but from a loss standpoint, since it was brought up, I do the perinatal bereavement program at the hospital that I work at. And we are talking about, private insurance versus Medicaid. And something that is very frustrating to me is, so recently I had a Black mom who lost her full-term baby, and she had a job with Blue Cross Blue Shield insurance. And that was great, but she couldn't pay her rent. She couldn't pay her utilities. So we were helping her with that. But Medicaid will cover genetic testing to find out what happened to the baby. And I don't have to battle them to do that testing, but private insurance, I do have to battle to get that testing covered. And I think there's a misconception there that because they afford private health insurance and that they have a job, that they can therefore probably pay that deductible or whatever it is. And that is not the case. And that's very frustrating as somebody who cares for that population of patients, because there's very little help available to cover that. I can help get utilities covered and all of that through our community health worker, but paying for genetic testing that's not covered is a different thing. So I don't know where that fits in all of that, but that is something I see a lot, and that's heartbreaking and very frustrating.
No, I appreciate that because I don't know that that's one I've heard before, honestly, and I'm happy to take it back and say, what does this look like? And it could be dependent on whether they're fully insured or an ASO. Sometimes we don't have as much control as we want, but knowing that or hearing that and being able to take it back and understand that it could be an issue is really helpful because we can start to have the conversation.
The reply that I get, and I don't want to just target Blue Cross Blue Shield, but it is primarily Blue Cross Blue Shield that I get that reply from, is that they won't cover genetic testing unless it has to do with colon cancer or breast cancer. So anything that we're looking at a cause of death so that we don't repeat another loss for that mom or that family, then isn't covered. And that's something I send all sorts of research and data to like argue. Every once in a while I'll get one to squeak by, but usually not. Yeah.
Write that down on my little note sheet right there.
Okay.
Well, and give me one quick second. I want to respond to that because what I heard there was we can't make assumptions about what resources people do and don't have access to based on their payer status, right? I mean, like, that's what I heard there is that because whoever this most recent person is that you interacted with, just because she had Blue Cross and Blue Shield still didn't mean that she wasn't still struggling in other areas of her life that we might not necessarily, they might not necessarily come to light for us. So.
Well, and to tag into what she said, this actually does, because it resonates for me in a case. Virginia talked about rising diabetes and all of those things. We had a young woman in Kansas who was gestationally diabetic. She was borderline gestationally diabetic during pregnancy. She told the providers that they said, you need a meter or the supplies. She said, I can't afford it. They said, well, we can give you a discount card. The cost for what she was needing to monitor her blood sugars was $100 with the discount card. She said to the provider, and this is documented in more than one place, I can't afford it. She walked out without that necessary piece of equipment to be able to test her sugars at home. She ultimately dies because she came across my desk. So I think my key takeaway from what I see with these cases is we need to do a better job of listening to what the woman says. We are not listening. And I want to say the other thing, you guys, thank you for what you do. This work has turned me into someone who doesn't really want anybody in my circle to be pregnant. I have a 39-year-old daughter, or 38, almost 39, who has had 3 babies since the age of 30. Her kids are 1, 3, and 5. It makes me anxious. They're in a good healthcare system, but death still happens. And you guys may not even know that your women die because they die later, but we need to do a better job of listening. So now I'm gonna shut up, Tara.
So there's a young lady in our presence who is pregnant and she's on my mind right now because we're talking about us. We're talking about us. Man, we could do another hour of this, which is why I like this moment, but I think we need to segue, if that's okay. The one thing I'm going to close with, which we will talk about this afternoon in-house, those of you online, I would challenge you to think about this. Recently, our facility transitioned to another EHR system. And we were talking at the system level about data collection. And I went back and I thought, you know what? I wonder what we can pull out. And I found out by accident that every single patient that had been onboarded to our new system was accidentally, and I mean that because nobody really knew, onboarded as a female, white, Caucasian patient. Just, oops. And so we stopped the train. It was just because I looked, other people were noticing it too, but the data wasn't right. And the data was extraordinarily biased and. So I would tell you all, there are lots of you online and in the room who think that you don't impact the data. Your charting dramatically impacts data. Did you accurately demonstrate her QBL? Did you talk about her breastfeeding? Did you, right? So your documentation and your protocols, you might sit here and go, this doesn't matter to me. It does. The reason we brought Virginia here is because her data is telling us at the bedside what we're missing, what we're not reporting, and how our protocols must change. On that note, we're going to shift gears. Virginia, thank you so much.
All right, wonderful. Thank you so much. All right. For our next presentation, we have Erica Hunter. She is the Deputy Director of DCF. She is the Deputy Director for Safety and Thriving Families for the Kansas Department of Children and Families. She has a background in investigating allegations of child abuse and neglect, supervising frontline staff, and reviewing high-profile cases or critical incidents for DCF leadership. In 2018, she became the administrator for the Kansas Hotline, receiving reports of child abuse or neglect. And in 2021, she became the Deputy Director for Safety and Thriving Families, where her team is continuing to reimagine child welfare in Kansas. Please help me in welcoming Erica Hunter. It's it. We do a little dance.
Yeah.
Clicker?
Yep. All right. Good morning. Can you guys hear me? Okay, good. So I'm just gonna first say that this is the first time I've done public speaking like in front of people pre-COVID. I don't know how well it's gonna go. I'm just giving you guys fair warning because I'm used to like having things in front of me and I can read off to the side. So here we go. All right. So she did an introduction for me, so I won't go over a whole lot again about myself, but
feel free, like I'm a much more informal presenter. And so if you have questions as we go, feel free, you could write it down and I can answer it towards the end because maybe I didn't answer it. Or if it's something you really want to know at that moment, raise your hand or something and I can always answer it. So up to you guys. So today, I'm going to go into a little more depth about kind of the perinatal substance use. So a few months ago, myself and a couple of people from the Kansas Children's Service League, so KCSL, presented on perinatal substance use, supporting families, and I think it was the period of purple crying. And we had a great response from you guys that said, hey, we want more information. We want to have some case studies. We want to do some more conversation. And so that's what this is. And so I want you guys to get out of this what you said, hey, I'm over here and I said I want more information. So that's what we want to give you today. So I'm going to breeze through a couple of these first slides because they were exactly what we talked about at the previous one when we did it online. But I just want to get your brains back into kind of that thinking. And then we'll go into some of the case study information that we have. So sound like a plan? All right. So here are the learning objectives today. I keep wanting to look over here, even though it's like right in front of me. I don't know why. Okay, so here's the learning objectives. So we're going to talk about risk and safety and kind of from your guys' perspective, thinking of what that risk and safety is, because if you guys can help us identify what risk and safety are, it helps us when we're looking at those initial screening decisions at the Protection Report Center. And it also helps when we're out working with a family. If we hear from you, some of those things you guys know are those risk and safety concerns. And then we're going to talk about what we call protective factors. So protective factors, again, it's just things that kind of help mitigate some of those risk and safety factors. So things that you guys are aware of that just help us make those better decisions. Then we're going to talk about supporting families. So kind of thinking in the role that you have, how can you support families? And then what is it that collaboration looks like with DCF? So that's what we're going to talk about today. All right, so this is as perinatal providers, kind of what can you do? And last time we talked to you and we gave you what that workflow was that was developed in conjunction with KDHE. With Kelsey Therese, and there was a whole group that helped develop that along with DCF. And so one of the first things to do is think of that perinatal substance use like screening that you can do. And so there's different tools that you guys can use in order to do that screening. And so it's administering that screening tool, seeing what those results are, talking to even that parent about what mandated reporting is, especially if it does look like it's something you're going to have to report. So what does that conversation look like with them? And then kind of evaluating their needs. And so, you know, depending on what that evaluation says, what can you do to help that person kind of move forward in what their recommendations are? So what kind of treatment is available? What supports do they already have in place? What are they already accessing? What are they already doing? So just kind of a lot of different things that you'd be thinking of when you're thinking, what is it that next step is if I have a parent in that evaluation saying that they're needing some sort of the next step, they're needing something additional for support related to substance use. And so then again, you guys are interacting with not just one individual group of people. You know, a lot of people that we interact with are probably only dealing with people that are using substance use, or there's just concerns about abuse or neglect in general. You guys also have that other group. You're dealing with the pregnant women who are possibly using substances, and you're also dealing with, when they're at the hospital, infants that might be born positive. So you kind of have a lot of different people that you would be working with. And so when to make a report to DCF, I know we went into a lot more detail last time about different times you might be making reports on those families. And I just wanted to kind of, again, highlight the amount of different times, the different people that you might be interacting with, the different situations that you would be interacting with, because the role that you're in, you see people that a lot of other people aren't seeing. And so that's what makes yours kind of unique in what you do. So then this is one that is just sort of still confusing. So I might go into it a little bit more again. So in Kansas, we have, okay, so let me back up first. So the federal government actually has something that is called the CARA Act. And I do this every time. It's something and Recovery Act. I can't remember the first part though. I'm sorry. I should have wrote that down. I think it's probably on notes somewhere. So the federal government has an act that they initiated back, I think it was in 2016. And with that act, it wanted to really start looking at how many infants did we have that were substance affected. And so they wanted to know, not necessarily that they're just born positive, but did they have some sort of impact from the parent that's using? And if they did, what is it that we can do to make sure that we're kind of just putting services around that family so that we don't continue to see ill impact or that child end up needing to be removed? So there's a couple of different things in Kansas that we have that we do. So for a really long time, I think it's been since 2006, Kansas has screened in cases of pregnant women using substances. We call them PWS cases. And so we've had pregnant women using substance cases for a long time that we've been able to work with families. And when we get those cases, we're able to refer them to a family preservation service. We can help get them into inpatient treatment if needed. And so really it's kind of it's a service meant to have that infant not born positive or not be affected by substances when they're born. So that's kind of the intent behind ours, is we don't want to see that child come into custody. What we know with those PWS cases is they're often the most difficult for us to work with, because usually you're not calling us most of the time for pregnant women that are using marijuana, that maybe a doctor has said, use marijuana for nausea, something. A lot of times we're seeing the cases where it's a person who showed up at the emergency room, they're 28 weeks pregnant, they're on meth, and they're homeless, and they're this, and they're this, and they're this. And so those are the ones that even for us, it's really hard to provide services because we can't locate them half the time. After they leave that hospital, we can't find them again most of the time. So that's one type that I don't know how much I went into last time on it. But then we also have our infants positive for substances and our substance affected infants. So I'm going to go through kind of just some of the differences between the two. So for the infants that are positive for substances, there's not a statute or anything in Kansas that says we have to investigate those, or that you guys need to be calling in reports on those when you're concerned about an infant that's positive for substances. It's more just kind of over the years, DCF for a long time has taken what we call non-abuse neglect cases. And that's what this infant positive for substances falls into. So it's a case where there's concerns that this infant was positive, but there's no impact from the infant. So that's kind of what the difference is going to be. So substance affected infant, there is information in Kansas statute that if you have an infant who was born and identified to be affected or has withdrawal symptoms resulting from prenatal exposure to legal or illegal substances, then those are something that are, as a mandated reporter, you would call in. And so you guys know what the symptoms are. I'm not going to read through the examples because that's probably not even a whole list of all the different things you might see. That's just ours to help us know different things. And so that's the difference, is we may have an infant who's positive for substances, but you're not seeing any sort of an impact or anything on them. And then the substance affected is the ones where there is something that you see because of that substance use. So you may have us, if you make a report on a family because of substance use, and maybe there is something that infant, I saw one recently. So there was some sort of something happening with that infant at the hospital. They were having to stay in NICU. So our staff were calling back and saying, was it because of the substance use? Like, is that the reason? And they said, no, it really had nothing to do with the substance use. This appears to be, and they kind of gave a better explanation. So you may have our staff calling and asking you so that they're better understanding, because we might not have any idea. So that's one of the things to really help us understand sometimes your concerns, is even letting us know, is it because of the drug use that we're seeing whatever some of your concern is? That can just help. So with the infants positive for substances, we do not have to do what's called a plan of safe care. It's something at DCF that we do that actually we would love to be able to figure out how we collaborate more with prenatal doctors, hospitals, and really create a good plan of safe care. Right now, DCF's kind of just been on our own creating them with families, but the concept behind plan of safe cares is specifically for those substance affected infants. And it really is meant to be a very wraparound service, making sure that everybody who's involved with the family knows what's happening and creating kind of not necessarily a safety plan, but a plan of what's going to happen if they start using again, what medical appointments need made, just all kinds of things to help that parent. So again, that they're not going to continue using. That's the goal. So they're kind of confusing, and we take two different kinds of things. And so you guys may not have any idea what it's getting screened in for or not. But that just helps you know in Kansas kind of what it is statutorily we have and what we potentially can work with families on. So after you guys have called in a report, so we have a lot of different teams at DCF that we have. And so the ones that you would be interacting with from DCF, if you're calling in a report that is on an infant's positive or substance affected infant, or just any concern that you might have, the person who gets assigned that assessment is what we call an assessment prevention or child protection specialist. And so their job is to really go out and continue to do more assessments with that family, make service referrals, and make a finding decision. And so not every single case, though, has a finding decision. So those infant positive for substances does not have a finding decision because it's non-abuse neglect. And so we don't make finding decisions on non-abuse neglect cases. Finding decisions would be made, though, on the substance affected because it's considered I think it's considered a neglect case. And so there would be a finding made on it. I'm going to keep moving on here so we can get to some of these case studies. So over the last few years, DCF has really had a movement of trying to get the communities involved with our families and really helping be a partner in that, because we know that DCF alone is not child welfare, that we really takes the community to help us make healthy families. And so what we really like to think, and some of what we've heard even some of our communities say and some of DCF say, is the people I'm working with, the kids I'm working with, they're going to grow up in my community and they're going to be adults someday. And so how do we make sure that those kids, the kids now, become healthy adults in my community? And so that's really a way of thinking of it, is helping take that ownership of that these kids that we see today are eventually going to be the adults in your community, and how do we make them be healthy adults? So everybody plays a part in a child growing up. So this is just a little bit more about that shift in perspective that we've been talking about, and you guys can go to the KCSL training that is about that if you want more. So I'm going to kind of just breeze through that here. And again, this may some be more for people who are maybe more of our teachers, people who see kids kind of more on an ongoing basis sometimes. But if you have a parent that you're working with who's coming in for prenatal appointments frequently and they're running into things, there's a lot of different places you can refer them to go get assistance. And this list isn't even probably the most up-to-date and great list that I have on here. So then we also have this 1-800-Children's Network. And this is, so if you have a parent who's struggling and saying, I don't have something, I need help, just kind of asking questions, I need somebody to talk to just get some ideas on different things, this is a great number that they can call. And it also has resources listed out by county. If you go to their website, or you can download their app. And so you can, I want to know where a food bank is in my county, you can go to their website and type in your zip code and it'll come up with all the different resources that they have there. So great resource, 1-800-Children, and it's sponsored by KCSL in partnership with DCF. So, okay, now to the case studies. So I asked one of the workers in one of our counties if they could help give me some ideas of some cases that they see. And so they gave me quite a few different ones that they're like, here's some examples of things that we see. So I kind of know what the end result is on some of these, probably not in great detail. I tried to memorize what I could, but this is just going to help us kind of talk about it. So what I'm going to do is, this is not the real name of these people. I just picked random names to have on here. So we're going to talk about the Harris family first. So what we received was, it was a report that said mom and dad lived together, but when we started looking at it, I don't really know if they did, but for some reason, all of our addresses said mom and dad lived together. But when I started kind of more looking at it, I don't think dad actually lived there. So I don't know why that was the address that he was given, but the reporter made it really seem like dad lived there. So mom had an extensive history of drug use. And she had admitted to using methamphetamine the week prior to giving birth at the hospital. Mom also expressed that she was having some significant mental health needs, and she needed some sort of mental health treatment. She'd had no prenatal care when she came in, and she said that she also had 2 older children that had been adopted. There were no details around if that was DCF had assisted with the adoption or if at birth she had had them adopted. I couldn't tell. There was no information. She had expressed at the hospital that she was actually interested in putting this infant up for adoption. There was no concerns about the infant at birth, so there was no indication of impact from mom's use of meth. And there was no information on if she had any extended family support or kind of any community support or anything that she had. So I'm going to ask you, and we're going to kind of walk through. So this is where I need some participation. So we're going to go through and just kind of talk about what are some of the risk factors that we saw in this? What are safety concerns? What are some of the protective factors, support services that we know of? What referrals could be made for that family? Discussion on reporting to DCF, and how could you partner with DCF in this case? So what are some of the risk and safety factors that you heard me talk about with this family? The recent history of the methamphetamine use? Yes. Yeah. Her mental health? No prenatal? Yes. So are those, when we're thinking of those, are those risk factors or are they safety factors? Both. And so when we think of, so this is kind of, we'll talk, I'll try to explain a little bit so that you can understand some of where DCF thinks when we're asking like risk and safety, or we're talking about things. So risk factors are kind of like that future danger. So there are things that are maybe happening that they're a situation where there might be future danger might happen because there is this, what we know over here. And safety is something that it's happening right now, and we need to do something about it. So when we think of the drug use, so her meth use is a risk factor because it could lead to a future danger. So when we think of like safety, it's something that is, okay, one of the examples that really has nothing to do with child welfare, and it's kind of a weird example, but I hear people use it, is, so you're driving down the street and you see the signs that say deer crossing next 2 miles. So there's a risk that you could have a deer that runs out in front of you. There's a future danger of a deer. But if you're driving down the street and that deer is in the middle of the road, then there's a safety concern. And so it's again, it's a weird analogy, but it helps me sometimes think of, so with safety, that meth use would be if the infant had gone home with mom, uses meth and she basically leaves the house for 3 days and goes on a meth binge, and nobody's cared for that infant. So that's kind of that immediate safety. So we have this drug use that we know about with mom that is a future danger, because we know that there's behaviors that come along with meth use. There's bad decision-making a lot of times. And so that's kind of that danger that we see. So then you talked about the mental health. So that's definitely one too. It's a future danger. And this did not tell us what her mental health concerns were. So for me, when thinking about making that report, what information should we have provided so that DCF knows what is that mental health concern? Is the mental health concern that she's suicidal? Is it that is she bipolar? Is she depressed? Like, what is the mental health concern really, so that we can actually adequately assess it? So that's one of the things I saw when I was looking through here. So any other risk or safety things that you guys saw in here? Right. So kind of like, what is this with the other two children being adopted and not having a lot of detail about what that was? So it's kind of, it sits on that edge of risk of, well, she's had two other kids. She no longer has custody of. And it could have been that, she said, I'm not in a place to keep them when she left the hospital. And so it's not really a risk because she gave them up. But if she'd had them removed from her home, then that can sometimes kind of up the worries and the risk as to why was it her past kids were removed from the home. So yeah. Any other risk or safety that we have? The family support. Yeah. So that's just unknown. Like we don't know what there is as far as that. Let's see here. Okay. So do we see any protective factors or supports or services with this referral? So one of them kind of going back to, and this is maybe pushing it a little bit, but is her saying, she doesn't have it yet, but when she's sitting and saying, I'm considering, adoption, what does that look like from your agency when a family says that to you? Like, I don't work in that setting, so I don't know what happens. Like, are there adoption agencies that to get called to go to the hospital, or is it normally DCF? I think that's where I'm not sure. What is the process?
I'm planning on adopting.
So at our facility, we immediately have our social work come in and do an assessment and talk
Okay.
with them. And then we have referral services and they call specific adoption agencies.
Okay.
Specifically, Catholic Charities is usually what our hospital uses. And then they have people who come to the hospital, meet the parents, and then go from there.
Okay. And so, because that's what I thought happened. So then when I got this one, I was somewhat confused, the DCF referral. And so I don't know what happened though at the hospital, because there wasn't information to say like, maybe mom was being really wishy-washy. And so they, weren't able to get it going faster. I couldn't tell because the referral didn't have much. It just had one sentence that says mom is thinking of giving up the child for adoption. So that was one where there hadn't been a service or any contact made with anyone, but was that a protective factor that could have been explored? Is there something that instead of a referral to DCF was contact to that adoption agency to come out to the home, maybe the better option? I don't know, but it sounds like that is a practice. So then it makes me go back to, okay, what was happening at the hospital this day that they didn't make that call, that there's probably something else going on. But again, not having those details sometimes is just like, we can't see what the decision-making was and where it came from. So I forget that I can see right here. So what referral could be made for the family? I think I already said that one, but when you guys saw this one, are there other things that you think of, referrals that could have been made for this family? Behavioral health? Mm-hmm. And so when behavioral health, I just want to clarify. So is that something where it means in the hospital, it's a behavioral health unit, or do you mean that your hospital would make like a referral to outside agency of behavioral health? Okay, I see heads nodding. Okay.
Our maternal community health workers.
Okay. And so the maternity community health workers, are they again outside of the hospital?
They are, but we have some embedded in our hospital as well.
Yeah. Yeah. And so just starting to kind of see what it is, can we put in there for mom? Mm-hmm. And so when looking at this, what do you think as far as reporting to DCF? Like, and there's no right or wrong answer with this one, so, well, I don't know if I'd say right or wrong. I think there's a lot of different things you can take into consideration. And so sometimes, again, we didn't have a lot of detail, so it's hard to say what efforts maybe had been made by the hospital, what other things they observed, because this was very just factual information. There was no information on bonding. There was no information on her behavior. There's no information on willingness to do anything. So it's just very factual information. So what do you think about reporting to DCF? Do we feel like this is one that it was appropriate to have reported, or do we feel like maybe there should have been, it wasn't really necessary to have reported it?
To make a referral to DCF when there's a positive meth, I mean, that's what our social work has
So
told us.
so it's not necessarily required by DCF, but
Okay.
your own agencies may have policies or procedures or different things that say, if you have a person who's positive for this substance, we highly recommend, or we mandate that it is a referral to DCF. So, and again, that goes back to just certain substances, you're going to see a higher likelihood of those risk factors and not just one. Most of the time when you're seeing substance abuse, especially like meth, you're going to see there's homelessness, there's domestic violence, there's past DCF history. So a lot of times you're seeing kind of that pileup of a lot of those risk factors that then kind of escalate it, into the higher risk type of case. So, so it's not necessarily mandated by DCF, but again, your agencies may have certain guidelines or rules that they would say, these are types of cases we would want you to always call in. Yeah.
People always feel like making that report to DCF is kind of the safest option. And that
Mhm.
way, because we don't always know that history, if there is a past DCF, what happened with those other kids. And so having someone else's eyes on it is always helpful too,
Mhm.
where we may not be able to dig into all that. Our social work team does a really great job, but there's also that other layer that we look
Right.
to you guys
Yeah.
for.
And so kind of, because you guys have a very quick interaction a lot of times, like your interaction's not long-term. And so it is hard sometimes to be able to make an ongoing assessment or to do a very in-depth one. And so, when thinking of some of those families you do come in contact like this one, and I mean, this was one that I definitely would say you should make a report to DCF with all it was. Like the only thing that I said you could have done different would have been to contact the adoption agency and see if they would have came out and talked to mom and worked through that process with her. Then a report wouldn't have been made. But again, we don't know what was happening at the hospital. Sounds like that's probably a normal process. So why they chose not to call the adoption agency, then it sounded like DCF was, the best option to do. So because there are a number of different things in here that we saw as risk factors that are putting that, future danger in there, because we're seeing we have, extensive drug use mom's admitting to, immediately sitting and saying, I have a mental health crisis that's happening, even though we don't know what it was, saying she has 2 other kids that have been removed. So I think we're seeing, this is one that we would want to call in for DCF. So
Hey, Erica.
yeah. Oh. I agree with you. I'm not thrilled about it either. And foster care is the last place. Yeah. Yep. And I think that is something that's, in general across the entire nation, people are finally realizing foster care is not the answer. And foster care is really the last thing that should happen, that we should be really putting all those supports in and doing prevention. So the moment that you start to interact with that woman who's using, if it is when they're at their first visit for prenatal, that is when the intervention has to happen. Because if we wait until they give birth at the hospital, then you guys are all stuck, not knowing even what to do, being able to make an assessment within a couple of hours, having to make these decisions that can impact them for life. When if we had done something at the very beginning, it would make a huge difference. Right. She never came in. Yeah. It's hard. Yeah. Yeah. So this is where we hope, like, who else had contact with her? She's not just by herself. Like, somebody out there in the community probably had contact with her. She probably had mental health somewhere. And so it's just, and I think that's where we try to think of, there's no wrong door. So if you have somebody who walks into your center and they're not in a good place, they need help, how do you get them that help right then, instead of it being, you need to call DCF, because that person could have walked in that day feeling like they needed help. And if we turn them away, the next time we interact with them, they may not be in that same headspace. And so it's really trying to, the moment that you have the opportunity to engage with them, do it. And so that again, you're not going to interfere with what we're doing. You know, you're only going to help us in what we're doing and trying to do with those families by providing any of that support. So any of these referrals you said you would have made, make them, still make them, and contact DCF. You know, there was nothing wrong with still making any of those referrals, because all that does is you put additional supports in there that maybe we didn't realize would have been a good resource for her. So yeah. So then that kind of goes with,
Erica,
yeah.
can I ask you, sorry, it's
You're fine.
Jill.
Which one?
So this is something when you presented the last time and then it's come back around this time. And I think this is probably just something that probably we all struggle with. So a baby in particular, like in this case study, perhaps the baby was born and there was no concerns immediately, but we know that some babies don't exhibit those withdrawal symptoms until they've gone home from the hospital. So I think that's a hard judgment call for you on the front lines, right? About the substance exposed infant as opposed to the substance affected infant. So I just wanted to call that out, that I think that there may not have been an immediate concern within that 24, 48 hours that baby was present, but when that baby goes home, that's when those symptoms might start to exhibit, and they're already gone. They're out the door at that point in time.
And so that's a really good point. And so with our substance affected infants, so if that child, that baby goes to their, checkup after they're born, I don't know if it's 1 week checkup, I'm sorry, so they go to their 1 week checkup, and the doctor there, so the pediatrician notices something. Mom says that infant's being very, whatever, can't even think of words, but something. And that doctor could also say, well, I think it's from substance use. I don't know how often that happens though. I think a lot of times we don't see people diagnosing after, we don't get a lot of calls in from like pediatricians saying, I think this is related to the substance use from when they left the hospital. So, but it is for us something that we can assign up to, I don't remember what age, I think it's up to 12 months. We can still assign a substance affected infant. So if for some reason that infant ends up back in your hospital and you become aware of it, and they're there because of what they're now saying are probably related to that substance use, then another report could be made saying they're in here now, it is from that substance use, and then it could be looked at kind of in that other way. So that's just something to know, because I agree with you. There's sometimes that you may not see, and we know like with fetal alcohol syndrome, alcohol is legal, but you may not have a mom who presents at the hospital appearing as though they're an alcoholic because they didn't drink that day and it's out of your system so much faster. But maybe they did drink heavily throughout their whole pregnancy. And it's not until that child is older that you're going to even see, the signs of fetal alcohol syndrome. And so we know that there are times when it's not going to be immediately seen at the hospital. But you can call in another one. If they do happen to come back in, you get information that they are having symptoms now, then it can be something that can be, a new hotline can be made. Okay, so I'm going to go just to the next one here. All right, so this is the Parker case. So this report was called in, and let me tell you what happened with the Harris though, actually, because I know what happened with this one. So the Harris family, DCF did get the referral for it. They worked very quickly to get mom into an inpatient treatment facility. So they got her into an inpatient drug treatment facility. She worked with one of our providers. I can't remember if it was Family First or Family Preservation Services. So she worked with one of our providers and was able to keep her baby. Last that they knew, it's been over a year, like a little bit longer than a year since we've had the case closed, and when we've got no new intakes. So the assumption is that she's doing well with her baby. So in the end, it was a success. I think that they really worked hard to find ways for her to be able to keep that baby and be in an inpatient treatment facility. And I never saw anything about her wanting to give the baby up for adoption come up again. So I don't really know where that was. So in a way, it kind of worked out better for mom and baby that we there wasn't a call immediately from the hospital because maybe she just wasn't in the right headspace that day after she had her baby and she just felt overwhelmed. But they were able to set her up with success through services. So it was a good story in the end. All right. Parker case. So this one we had a meconium screening was positive for marijuana. Mom denies any recent drug use. She had received prenatal care. There was no concerns for the infant at birth. There was no concerns for mom's ability to parent the infant. She had all things that she needed when they asked about it. And she also has 3 other kids at home with her. It did not mention anything about dad, so I don't know if dad's involved, I don't know. But it didn't mention any other supports or anything. So, but this is pretty much what we got. So what are some of the risk and safety factors that we see from this one? So there's some sort of drug use that we had there. And it did not say like, so she denied recent drug use, but it like the report didn't say, well, she admits to using when she was first pregnant. So again, we don't know what is recent because it didn't go into detail. So yeah, so we have this risk of, we know there is some sort of substance use there. What other risk factors do we have? Okay, yeah, there's not, but and that's, you know, so there weren't many listed on this that we could see. So, and yeah, and I don't know, I should have put her age on here. That would have helped too, because sometimes even a risk factor can be, and it sounds bad, like we don't like to put it, but you can see sometimes like if there's a young mom who has, you know, several kids under a certain age, that can put them at higher risk just because there's a lot more stress that they might be going through. And so you do see that that can be a risk factor, but I didn't even think to put age on here of mom. So yeah.
It seems to me like something's missing because why was the meconium drug screen even performed?
I don't know.
You know,
Yeah.
something's missing. There was some indication.
So yeah, that's, and when you think of kind of like that referral or that information maybe needed reported to DCF, like if there was a concern, what was that to prompt you to do that meconium screening? Because I don't know. It's not done on every infant? No. Okay. So it's only done on select times. And so what kind of times are those when those meconium tests are done?
Quiet. Okay, so raise your hand and on the chat, yes would be the answer. Raise your hand if you have a current protocol in place that requires a meconium screen. In other words, mom has this risk factor, a meconium screen is done. That's what I thought. So the majority. So whatever she screened, you're asking a great question. I wondered that too. So what did she screen positive for that required, or did baby exhibit symptoms? So this is touching a little bit on your NAS, right? So the NAS folks, the neonatal abstinence syndrome folks, are thinking, holy cow, this is kind of opposite of what we all just did, right? And when do we call DCF? So I would tell you that we're all working really hard to work through what you're saying to us today.
Yeah.
It's hard because most of us have protocols, right? That say do the meconium screen if X, Y, and Z. Social work is called and providers walk in the room the next day and she's very upset.
Yeah.
Right?
Yeah.
Or we tried to start the DCF conversation when she was 12 weeks and saying something's not right. We want to help you. Let's work on an action plan. I like the idea you had. And then we get to delivery and the walls came in.
Right.
And so we all failed her.
Yeah.
And the meconium screen is positive.
Right.
Right.
Yeah.
So we've all been there, right? Yes, please. Here, take this.
Drug use, but uses the CBD with the THC in it. So they don't consider that drug use because it is legal in some states and but our state is not. So there's that.
I think it's also difficult because the criteria is different for every facility. Some people don't, like you showed, didn't have a protocol for doing it. Even maternal drug screening, like at our facility, if she has late prenatal care, less than X number of visits, no prenatal care, et cetera. But there are other facilities that it's every mom, every time. So I think that makes it a little more difficult too, especially with the increase in travelers and stuff that we're seeing on the inpatient side. How do you know what's what at what facilities? Are we missing moms? How do we handle that? So I think it makes the whole situation really tricky. Not to mention, then you have the issue of, did you consent for it? And if you didn't consent, how did that go about? Whose responsibility is it to consent? Should it fall on the provider or the nurse in that moment? It's just a huge, sorry, that's my big can of worms there that we're
That I
opening up in
opened
that
with
moment.
that one. Yeah, yeah. No,
It was
for me,
blowing up
it's
in my head as you were
learning.
talking.
Yeah.
I want to
Well,
contribute
and
to the can of
I just
worms.
want to add one quick thing, and that is also, it's what you just said, which was really good. You know, how are we defining drug use? I mean, did she smoke once? Like, and it just happened to be at the end of the pregnancy? And is that really drug? You know what I mean? Like, again, when we're talking about risk factors and safety factors, there's a lot that we don't know here that led to this.
I was just going to say, I'm not sure about other facilities, but at our facility, like confirmation on those drug screenings, it takes like up to a week to get confirmation back, and that's really bad too.
Does everyone in the room
exactly.
know how far back meconium screening goes for marijuana? Does everyone know like what the time frame is for a positive meconium screen for marijuana? It's the last 4 to 5 months of pregnancy. So when she's denying recent drug use, 4 to 5 months back is kind of far. Maybe she hasn't had anything in 4 to 5 months. Maybe she was in treatment and accessing treatment and she hasn't. So like in her mind, she's done like 4 to 5 months of really good treatment. She's not using anything. So yeah. Cord blood is different. So there are different timeframes for every single sample location that you're taking. So there's really good research out there around what the timeframes are for each different sample. Meconium is the last 4 to 5 months of pregnancy. So if you're thinking about that timeframe, that goes into your calculations when you're thinking about risk and safety, right? The other thing is that like who in here knows what kind of the most recent data is saying about marijuana use in pregnancy and risk factor for baby? Anybody know? It's about the same as tobacco use in pregnancy. So the risk, symptoms, all of that are about the same as tobacco use. So are we screening moms for tobacco use early enough? Are we doing DCF calls for tobacco use or to vaping? Right? Probably not. So if you're looking at what the data says, and you're considering that those are typically the risk factors for marijuana use for both mom and baby's health factors, I think that helps you like situate it in your mind. It's not a legal substance in Kansas. It is in Missouri. So like, what are you actually really worried about? To Erica's point, like, how does that factor into your like risk factor assessment?
And I think when you just said, what are you really worried about? Is it just that it's illegal? Okay. Alcohol is legal. There's medication that's legal that all cause just as bad, if not worse, sometimes, you know, withdrawal symptoms or symptoms. So I think that's a really good point of it's not necessarily about whether it's illegal or it's legal. It is about the impact that's going to have on that infant. And no, we do not screen for tobacco use, but we have had some that actually were substance affected. And we did screen a tobacco because the infant was in the hospital for almost 2 months due to the mom's like tobacco use, which I had never, ever heard of. And it was extremely rare, but it did end up getting assigned. So
I'm more concerned that she has 3 other kids at home. This is baby number 4, and we haven't talked about what support system
there
she
you
has
go.
in
Yes,
place, 'cause
that's,
that
and
would
I
lose
think
my mind.
that's what really sometimes to think of is it's not just about that substance use. It's about what else is going on with mom. Like, we don't want to set her up for if again, it's that there's no wrong door. She's at our door right now. Let's talk to her about this, you know, let's talk to her about her supports. Let's talk to her about the systems that she has set up, you know. Is she, you know, at least I did see they talked about everything she had and they listed that she had clothes and diapers and all that stuff. But again, how old is she? Is she 20 and or 25? And so now she has 4 young kids at home with her. You know, that's a lot for her. I can't imagine being 25 and 4 kids, you know, so What is it that we could do? So that's a great point as far as what could we have talked about. What about just reporting in general to DCF on this one? I see some head shaking. So people are saying, I don't think I would have called it in, or. Mhm. Yeah. So there was not anything that's necessarily concerned about mom and her baby that's at the hospital. But when you hear, you're saying, okay, well, I have more questions about mom and, knowing she's got 3 other kids at home, what does that look like for her? And so kind of just those other questions. And so when you think of that though, what is it that would, I'm probably not going to ask this right, but when you think of, okay, she's got 3 other kids at home, what are some things that you would worry about that would almost make you think you need to call in a report?
Do you have access to food resources, things like that? To me, those would be
Mhm.
important.
Water, like utilities, who's watching them? Are they in school? So kind of, we don't even know their ages. Like it just said she has 3 kids, but they're not even listed anywhere on here to know anything about them. So yeah. So seems like there's a lot more information kind of on mom that we may not be concerned about what's this specific thing as far as her drug use. So if she was just a single mom, not single mom, had 1 kid, I was saying that wrong. So if she's a mom with just 1 kid, and this was first pregnancy, marijuana use, would we have called in that report? No. And so it kind of is going back to what I see people thinking is, okay, but I want to know more about those other 3 kids. That would have been maybe more what my focus would have been if I was calling a report. And so I will say this one was screened out. So DCF did not do anything with this family. So it was not assigned for us to assess. We got that report. And again, we go and we're trying to look at what are those risk and safety factors you guys are identifying with that family? What are supports and services they have that maybe mitigate some of those? And so we didn't have any risk or safety. There was no information about those other kids. We didn't have history with her as a parent. And so we're not going to assign just for the marijuana use on that one. So then I don't know how long you guys want me to go, by the way. So you tell me. 10 minutes? Okay. All right, so then we've got the Morgan case, and this is mom tested positive for meth and amphetamines during pregnancy and at infant birth. So she had limited prenatal care. I feel like I don't remember what it said. When they said limited, I think she had 2 prenatal care appointments, if I remember. She previously has been provided drug and alcohol resources. She has no basic supplies for the infant. So she does not have a car seat, crib, bottles, clothes, food, formula, nothing. She has nothing. She has 5 other children that she does not have custody of, and they all reside with grandma in Texas. She reports that she has not told her parents or any of her family about her pregnancy. And she does not have connection to any community resources. So what kind of risk and safety factors do we see with this case? Whole thing there. Yeah. Yeah. She's got a lot going on. I mean, so she has, so just the testing positive throughout pregnancy plus at birth. So we know this use is very, very ongoing. She's been provided drug and alcohol resources at some point. She's not really followed through with them. And so what I want to highlight there though, is that somebody did because it was about the prenatal care. It was about that. And that was when she was testing and the resources provided. So at some of those prenatal appointments, she was getting this information on treatment, and there was that conversation happening, but she wasn't following through with it. So you're going to have that, you're going to have people where they come in, you can give them the resources and you see them, not want to have to be involved with DCF. They don't want it when that child's born to have DCF come to the hospital and see them. That is not pleasant for any new parent to have DCF show up in your hospital room with you. But that's what we do. And so, when you're talking to parents, and they're coming in, there is a substance use. How can we get them to want to, not have their child be positive? What can we do to support you? And you could tell somebody tried to do that. She just didn't follow through with it. Yeah, and just no supplies. There's a whole lot. There's a lot going on. Like you guys said, pretty much the whole thing, risk and safety. Right. She was not expecting, yeah, to go home. Or do we see any protective factors listed here? She did. That is, yes. Yep. So she did have somebody that she at least, and she did continue, she went at least twice. So she had some sort of a connection with prenatal care. Yep. And we don't really know what the drug and alcohol, what she did with the information. She could have gone. It just said that somebody had at least provided her information. So we don't really know. And so reporting to DCF. I feel like that's, I could see, yes, from those risk factors. And then is there anything you feel like you could do to partner with DCF? Are there referrals you feel like you could make for her leaving the hospital? Or what is it that you feel like could be set up for her as she gets ready to discharge? I think, and are some of you just kind of going, she shouldn't take this baby home? Is that where I'm seeing lots of like stares at me, like, what are you even asking to take her home for? Yeah, so, yeah.
I just feel like with patients like this, it's just a constant type of reminder and referrals, and you
Mhm.
just have to go over it over and over and over again.
Mhm.
You know, just like with domestic violence, a lot of times people don't do anything until they've heard it 7 or 8 times.
Right, yeah.
So it's just a constant referral, constant working with them, because this patient in this particular scenario is obviously not ready right now.
Yeah,
Hopefully someday down the road, she'll listen
yeah.
and make that choice. But
Mhm.
right now she's just not. So
Mhm.
you can have everything set up and partner with DCF, but it really falls in her lap of when
What
she's going
she's
to be
gonna
ready.
do. Yeah, yeah. And I think that, I think sometimes we as, providers, we get kind of burned out even by seeing some people who, when she tells you, I have 5 kids and I don't have custody of any one, of them, you kind of immediately are like, oh man, like you've had so many chances and opportunities, and why haven't you done something? That sometimes it's easy to immediately want to check out on them, to just assume that they're going to keep doing the same thing. And so I like when you said, we just have to keep telling them. It's like, sometimes, you may feel like she's already heard this 100 times. Well, maybe it's the 101 time that she really took it and she's going to go with it. And so, hearing it from multiple different people, hearing, all of that stuff is something that can just be impactful. Your words matter to people sometimes. And even if you are having to call in a report, being honest with them, there's a report being made. They're going to be coming out here. I don't know what is going to happen. But, I know that you can get through this, and how can we help encourage them? Even though we know this might not be likely that it's going to be successful, but how can we help them think, at least get through this next part that's here? So, I want to tell you what happened with this one. Can I hit escape and it'll take me to my notes? Oh, they're not. Oh, wait, let me go. Did I say Morgan? Okay. So this one, you guys can see it up there too. It's probably hard to read, but so this was a really high risk of removal. The mom was very disengaged with her baby at first, and all of her other children had already been removed. She was very hesitant to even want to bond with this baby, because if you think of, you have 5 kids, potentially she probably had them all removed at birth. And so she's not wanting to bond with them, because for her, no, like she doesn't want that hurt. She doesn't want that emotion. And oftentimes we see that as they're not bonding with them. They don't know how, but really it's a mechanism for her for self-preservation. And so she was very hesitant to bond with baby because she was assuming they would take it. So they did a team decision-making meeting. So they call them TDMs. So we had one of those. We have to do them when they meet certain criteria. So this case met certain criteria. And they gave her very specific things that she would need to do to ensure that there was a safety of her baby. So after the TDM, they saw a noticeable difference with mom, both in her willingness to work with them and to trust her and to care for her baby. So they had services they put in the home, and they still, again, this is another older case that they had. and she still has the baby with her. So although it sounded very bad, you know, there is success. And so I think that's, again, when we think of even, I mean, this is a bad one, so it needed called in because, you know, somebody needed to go out and protect that baby. And we didn't, the results could have been worse. But what we see is that somebody gave her a chance and somebody had those conversations with her. I'm sure there were some really difficult conversations, especially in that TDM. They are 2 to 3 hour long meetings. They are with family and friends that she probably hasn't talked to in a while. And there's a lot of people putting her on the spot to really transform and do something different. And so I just think it's good to let you guys know that, you know, sometimes even though you called in and it seems like one that there's no way she's going to keep this baby, that baby's going into foster care. That's not always what happens. And so there are successes. So, all right, well, that is all that I have. So thank you guys very much.
Thank you.
Okay, so this is my opportunity to ask you to please scan the QR code for session number 2, and please take the evaluation. All right. Well, for those of us who are in the room, lunch is here, and I don't want to stand between you and lunch, but we do officially need to convene our KPQC business meeting. So I am officially opening that meeting today. And I mentioned this earlier this morning, but we would like to take this opportunity to really recognize our KPQC Executive Committee. So if you are in the room or if you're online, I don't know if they can all see each other or not, but if they want to go on camera and wave, I would like to take this opportunity to introduce our Executive Committee. So Dr. Busenhart, she is our past chairperson. Dr. Nguyen, who is our chairperson, and she welcomed us this morning. We have a vacant chairperson-elect position right now. We have Jerry Harvey, Dr. Swan, and Dr. Bry, who is here, and she's waving, wonderful. Dr. Smith, Kristen Perez, who is also here. It's nice to meet you, Kristen. Kirsten Green, Karen Brayman, Dr. Morgan, Dr. Bettinger, and then you know myself, Tara, and Carrie. All right. Before we go to lunch, I do want to take this opportunity to please remind you about the upcoming fall KPQC conference, which will be in partnership with Kansas A1. It will be an in-person meeting in Salina, Kansas on Friday, October 20th. I have that correct. I wish I had a slide to put back up here for you. But we look forward to having you join us there in person. And this concludes our official meeting that took 3 minutes. And so those of you who are online, we'd like to thank you for joining us this morning. We hope that you took away some amazing nuggets of information from our presenters this morning and from the conversation that was had here in the room. We want to thank you, and we hope that you have a great day. For everyone else who is here in the room, your lunches are set out and ready for you in the back. Just a couple of quick announcements. If you are the 4th trimester champion for your facility and you do not have a t-shirt, please go see the registration desk while you're out there picking up your lunch. And I feel like there was something else. Oh, yes. We brought mom cards for you if your facility needs them. They are here in the back of the room. There's both Spanish and English. So take whatever you need back to your facility. And then especially for our new facilities who may not have received the maternal warning signs patient education guides, please come see me and I will give you those to take back to your facility as well. And with that, we're going to lunch.